Hi everyone, I'm Vadanya. Today I'll talk to you about the syndrome of inappropriate antidiuretic hormone secretion, which is known as SIADH. Now, this is the most common cause of euvolemic hyponatremia, and we'll study how this occurs in the subsequent slides. So, the primary defect in SIADH is an increase in the levels of ADH in the body. So let's first start with the normal physiology of ADH, which is the antidiuretic hormone. So this is a nonapeptide hormone which is also known as Arginine Vasopressin. So it is a nonapeptide, which means that it is a 9 amino acid peptide with a cyclic ring formed by this disulfide linkage. It is also known as Arginine Vasopressin due to its effects on the blood vessels, where it acts as a vasopressing substance. So AVP or ADH, it is synthesized in the hypothalamus in the magnocellular cell. So they are magnocellular secretory cells in the hypothalamus, which synthesize the precursor hormone, which is pre-pro-vasopressin. Now this pre-pro-vasopressin, which is cleaved into the various fragments, that is vasopressin, neurophysin and copeptin, then all of these are transported. So here they are synthesized and then they are transported via axonal transport down into the axons and to the pituitary. In the pituitary they are stored in the axonal vesicles, and on stimulation they are released into the blood vessels around the pituitary. So these are secreted from the posterior pituitary. So let us see what stimulates the release of ADH. The primary stimulus for ADH release from the pituitary and hypothalamus is hyperosmolality. Now this is said to be the most sensitive stimulus for the release of ADH, saying that even a 2% increase in the osmolarity will stimulate the secretion of ADH. Another stimulus is the decrease in volume. Now this decrease in volume will stimulate the RAS system and lead to the production of angiotensin II, which will also stimulate the hypothalamus to produce ADH, to release ADH, and you will have decreased atrial receptor firing. So these are the receptors that are located in the atrial wall and they respond to stretch. So normally what will happen, there will be a tonic inhibitory tone on the secretion of ADH through the continuous firing from the atrial receptors. But when this firing decreases, as in the case of low volume, then that negates the inhibitory effect on the hypothalamus and causes it to release ADH. Now what does the ADH do? So before that, one more thing. So this decrease in volume is a very potent stimulus for the secretion of ADH. So while hyperosmolarity is the most sensitive, the decrease in volume is the most potent stimulus for the release of ADH. Now, again, what does vasopressin finally do? So vasopressin acts via its receptors V1 and V2. So the V1 receptors are also divided into V1A and V1B, also called as V3. So V1B and V3 is same, and you have V1A. So these V1A receptors are located on the blood vessels and they cause the constriction causing an increase in the systemic vascular resistance. This will lead to an increase in the arterial pressure. The V1b receptors or the V3 receptors are mostly present. The V1b or V3 receptors are present in the hypothalamus, and they cause the secretion of ACTH. The V2 receptors are located in the kidneys and they cause increased fluid resorption and thereby increasing the blood volume and finally increasing the atrial pressure. Now the vasopressor effects of ADH stimulated by the V1a receptors are mostly seen in pharmacological settings. That is, in normal physiological settings, we do not see a very big effect of ADH on the blood vessels. The main pharmacological action of ADH is the action on kidneys, that is the solute-free water resorption, and this is what we'll study now. How does it act on the kidneys? So this is a diagram of the a cell in the collecting duct. So the V2 receptors are located on the cells of the DCT and the collecting duct, and they are located on the basolateral side. So this is the basolateral side. This is the ADH receptor, which is the V2 receptor. Okay, so the ADH that is present in circulation, it will come and bind to its receptor. So this is a G protein coupled receptor. So the G protein coupled receptor, what it will do is it will stimulate adenyl cyclase. It stimulates adenyl cyclase, which causes an increase in the levels of CAMP. When CAMP increases, it causes the activation of several protein kinases. So these protein kinases, they will cause phosphorylation. They will cause phosphorylation of aquaporin 2, and this will cause it to translocate to the membrane. Now the aquaporin 2 is a water channel which is selective for water, so it will not let any solutes enter along with the water. So once it translocates to the luminal side, this is the luminal side, which is the lumen of the kidney tubule, the water will start entering and it will go to the basolateral side and into the circulation through the aquaporin 3 or 4. So this is how ADH will act via its V2 receptors in the kidney and cause solute-free water resorption. And it will increase the blood volume. Now, since this water resorption is solute free, the subsequent expansion in the blood volume will lead to a decrease in the levels of sodium, causing a dilutional hyponatremia. So let us see how the secretion of ADH is regulated. So like I told you, the plasma osmolality is the stimulus for the activation of osmoreceptors in the hypothalamus. We'll see now how the osmoreceptors are activated, and the activation of these receptors will cause the release of AVP. The osmoreceptor activation will also lead to the activation of the thirst mechanism, causing a drinking behavior in the individual, which will subsequently decrease the plasma osmolality. Okay. The AVP secretion will also cause the water resorption from the kidney, which will also decrease the plasma osmolality. So let us see how osmoreceptors sense the osmolality. So this is the diagram of a osmoreceptor neuron. So it has these channels on its surface which are stretch inactivated sodium channels. So what does the name tell you? The name tells you that when the membrane of the cell is stretched, then these receptors will be inactivated. They will stop firing. So in hypotonic cases, there will be movement of water inside the cell leading to swelling of the cell and stretch of the membrane. This will inactivate the sodium channels and they will not fire. So there will be no AVP secretion. However, in the opposite case, when you have a hypertonic environment, then the cells will shrink because the water will move out of the cell, and this will cause the activation of these sodium channels and leading to their increased firing. Now this will lead to the formation of an action potential down the axon, which will subsequently lead to the influx of calcium in the terminals. This influx of calcium will cause these granules, the storage granules of AVP, to be released. Okay, so there will be increase in the AVP secretion. So basically we have a set point of this osmoreceptor activity, and that will give us a basal ADH level. Okay. Next, let us study what goes wrong in SIADH. So the primary pathology in SIADH is basically an excess of the antidiuretic hormone. So again, through its action on the V2 receptors on kidneys, like we have seen, it will cause increased water resorption. This will lead to an expansion of the ECF volume and hypoosmolality and hyponatremia. Like I told you, this was dilutional hyponatremia that was happening. But the expansion of the ECF volume should also cause the activation of counter-regulatory mechanisms. So we have mechanisms that regulate the blood volume when it is too low or when it is too high. So here the counter-regulatory mechanisms are getting activated, such as the release of ANP. So ANP is released from the atrial myocytes in response to stretch. Okay, when there is stretch of the atrial wall, it causes the release of ANP from atrial myocytes, and this ANP acts on the kidney tubules and causes natriuresis. Okay, so basically it blocks a sodium channel and it blocks sodium resorption, and then water goes along with that. So it causes natriuresis. So again, you already had a situation of hyponatremia due to the dilutional effect of the volume expansion. Now you're still losing more sodium because of the action of ANP, but the water is getting resorbed because you still have excess ADH. So you're losing more sodium while your water levels might be maintained. So your volume of blood volume is maintained. That's why it is euvolemic, because again the water is getting resorbed. Okay, and you're losing sodium, still losing sodium, so it is euvolemic hyponatremia. Okay, so what causes that primary increase in SIADH, in the ADH levels in SIADH? So one, it might be grouped into 3 or 4 factors. One is the ectopic production that is seen in many cancers. Okay, so in these malignancies, there is an abnormal expression of the AVP-NP2 gene. Okay, so this causes an ectopic production of ADH as a paraneoplastic syndrome. Okay, another cause is increased eutopic production. When you say eutopic, that means it is getting released from its actual site, which is the hypothalamus. But there is something which is causing the stimulation of this hypothalamus and causing it to release ADH. Okay, so what is it that is overstimulating? So they might happen in the case of acute infections. So mostly you have lung diseases or lung infections such as pneumonia, which result in the increase in ADH. Might also happen in stroke and neurological diseases. So what is the mechanism in acute infections? There will be an excess of cytokines released, and these cytokines have been hypothesized to stimulate the hypothalamus. In stroke and neurological disease, it is a direct stimulation of the hypothalamus as it is a CNS dysfunction. In lung diseases, they have also said that the decrease in the PaO2 or a decrease in the oxygenation can also stimulate the hypothalamus and cause it to release ADH. There might be some iatrogenic causes for the increase in ADH, which can happen due to the administration of Arginine Vasopressin or Desmopressin, which is the treatment for diabetes insipidus. So it can go all the way to the other end of the spectrum and cause SIADH. Oxytocin in large doses also causes SIADH because it has a structural similarity. It has a high level of structural similarity with ADH. Now, what is nephrogenic SIADH? So all these nephrogenic SIADH is due to an activating mutation. So it is due to a mutation in the V2 receptor, which will cause it to be persistently active and therefore resulting in more action of ADH. Okay, so these are the common causes of SIADH as given in Harrison's. So you have carcinoma of the lungs, especially the small cell lung cancer. Then you have head trauma, infections such as pneumonia, and following the administration of several drugs which can stimulate the hypothalamus to release more ADH. Let's move on to the clinical manifestations. It's been seen that it might be patients might be asymptomatic, or they might present with symptoms depending on how fast the ADH is following and how fast the sodium is falling or how much the sodium is falling. So if the rate of fall in sodium levels is very fast, then it will give rise to the acute symptoms of hyponatremia, which is headache, confusion, nausea, vomiting, convulsions, and coma. If there is a slow, sustained fall over weeks or years in chronic diseases, then it will cause chronic symptoms which are a little more vague, such as decreased reaction times, cognitive slowing, and ataxia. So again, you have to pay attention to those symptoms that might indicate the cause of SIADH. For example, if there is a malignancy, then there will be loss of weight. If there is an infection such as pneumonia, you might have cough, you might have fever. Okay. You have to take the drug history to see if the patient is on any drugs which might cause SIADH. On physical examination, you have to look for signs of volume status. Now, as I told you, SIADH is a cause of euvolemic hyponatremia. So you should not have any signs of volume status disturbance. What are the signs of volume status disturbance? Again, if it was hypovolemic, you might have signs of dehydration, such as reduced skin turgor, and dry tongue. Again, in cases of hypervolemic hyponatremia, you will have signs of volume overload. So you could see edema. But in patients with SIADH, you have none of these signs because it is a euvolemic condition. So here you can see the differential diagnosis. So you want to distinguish whether the cause of the hyponatremia, which is giving you the symptoms of confusion, of anxiety and nausea, vomiting, whether all those symptoms are occurring due to which sort of hyponatremia, whether it is hypervolemic, whether it is hypovolemic or euvolemic. So you'll see that in hypervolemic, you can have a history of congestive cardiac failure or cirrhosis or nephrosis. In hypovolemic, you can have postural hypotension, which will basically signify a volume depleted status. Then there might be other causes of the loss in sodium, which can be due to adrenal cause, in which serum cortisol levels might help you. So you can look at all these parameters and decide what is the cause of the hyponatremia in patients and whether it is due to SIADH. So what are the investigations that you'll do? First, you'll check the plasma osmolality. So the plasma osmolality will be reduced in SIADH due to the expansion of the volume. The serum electrolytes, especially the sodium, will be decreased as it is euvolemic hyponatremia. There is still renal loss of sodium, so you're still losing sodium from your kidneys, but its levels in the urine will vary according to the diet, which is as seen in normal people. It will vary according to dietary intake. The urine osmolality will be increased because of excess ADH. The kidneys are not able to dilute the urine. Okay, so the urine osmolality will be increased. Burn and serum creatinine may be low or normal. Glomerular filtration rate is increased due to the hypervolemia initially. Okay. Plasma ADH or AVP can be used, but they are not used very frequently. You can do imaging, various sorts of imaging to look for the cause. You can do X-rays to look for any pulmonary lesions. Okay. One important test is a water load test. This we are doing only in patients who have moderate hyponatremia. We don't do it in patients which are having severe hyponatremia, because then you might precipitate a crisis. Okay. So only for moderate cases in which you are not sure, in which you are ambiguous about the cause of hyponatremia, then you can do a water load test. And basically what you do here is you give 20 ml per kg of water to the patient to be consumed over 30 to 40 minutes, and then after 4 hours you'll check the serum osmolality, the urine osmolality and the serum sodium. So you will find that in normal people the serum osmolality will go down because of the volume expansion. The urine osmolality should remain normal. The serum sodium levels should go down. But in people with SIADH, this response will be suboptimal. That is, they will not be able to decrease the osmolality of the urine. Okay, so their urine will still be concentrated because the kidney is not able to dilute the urine. So if you get a suboptimal response, then you can suspect SIADH. So Barter and Schwartz described the first case of SIADH in 1967, and their criteria is still being used right now for the diagnosis of SIADH. So what their criteria was: hyponatremia with corresponding hypoosmolality and continued renal excretion of sodium to the action of BMP. The urine will be less than maximally dilute, because even there's excess ADH, so it is not allowing the urine to be maximally dilute. There will be absence of any clinical evidence of volume depletion, like I told you. There will be no signs of dehydration, no postural hypotension. There will be absence of other causes of hyponatremia, and importantly, the correction of hyponatremia with fluid restriction. So now we'll see the treatment, and we'll see that fluid restriction forms an important part of the treatment of SIADH. So depending on how the patient comes to you, whether it is an acute or a chronic case, that will justify your treatment. So when there is hyponatremia, we want to correct the sodium levels, we want to make it normal, but we don't want to do it too fast. We'll see why. So when we are correcting the sodium levels, we will give 3% hypertonic saline in an acute situation, okay, and we'll restrict the fluid intake, okay, and we want to increase the plasma sodium and osmolality, but we want to do it slowly, only at a rate of approximately 1% per hour, to reach about 270 or 130 of osmolality and sodium respectively. So why do you want to do it slowly? The thing is, due to the hyponatremia, suppose this is a neuron, it was all swollen up. Now suddenly you will so it was covered by the myelin sheath, and suddenly you're increasing the osmolality of the surrounding, and this will cause a shift in water immediately out of the neuron. Okay, this will cause shrinkage if you do it suddenly, and this is a complication known as central pontine myelinolysis. Okay, so this is a dangerous complication and you want to avoid this. So you correct the sodium slowly, about approximately 1% per hour with a hypertonic saline infusion. You can also give Vaptans, which are V2 receptor antagonists, given IV. So there is a Vaptan, Conv Vaptan, which is given IV, and it is a V2 receptor antagonist which can be used in a acute situation. Again, you have to keep monitoring the serum sodium to see that you do not correct it too rapidly. For chronic cases, the mainstay is restricted fluid intake again, or you can also give oral Vaptans like Tonivaptan,